Rotterdam, yes.
Hi, guys, we are live now. Hi, everybody.
Hello, Nita. Well.
Okay. Hi, everybody. Hi. Welcome to Congenital Heart Academy. We are very happy to start another session of the Fetal series. And we'd like to thank Dr. Rima for doing that, for organizing these amazing meetings. And today we have 3 great speakers and a lot of great panelists. So please type your questions on the Q&A chat box. And then we are going to be able to answer during the discussion all of your questions. So now I'd like to welcome Dr. Rima, and she's going to be the moderator of this webinar today. Thank you very much for joining, guys.
Hello, everybody. And it's a pleasure and honor to start this webinar on behalf of Congenital Heart Academy. And we have 3 world eminent operators in fetal hearts. And we're going to talk for about 1.5 hours. They're going to talk for 1.5 hours, and then we're going to have 30 minutes for discussion. So the total duration of the webinar is 2 hours. If you have questions, please keep them. We're going to have 2 to 3 questions after each talk, and then at the end you can type your questions, and we'll be very happy to ask the speakers to answer them. Now, the first speaker is going to be Dr. Carlos Pedra. And he's from Brazil. And could you please, Dr. Pedra, could you please introduce yourself?
Yeah, well, thank you, everybody, for this kind invitation. I'm really honored to be here. I think both Wayne and Gerald had a huge impact in our practice in fetal cardiology. So this is an initial acknowledgement. Thank you, guys. And I'm the head of the cath lab for congenital heart disease at Dante Pazanese in São Paulo, Brazil. And I'm currently running the ICU as well. So I'm very busy and tired, but hanging on. So let me share my screen. So this is an update on our fetal interventions in São Paulo. Of course, this is a teamwork, and I thank Simone, who is my wife, and probably this is the main title, my main title. I'm her husband, and of course, Fabio as well. I don't have for this talk, and from 2007, we've done 98 procedures, fetal cardiac procedures in 93 patients, 10 septostomies, 43 pulmonaries in 40 patients, 45 aortics in 43 patients. Our mean gestational age is a little bit high, just 27 weeks, and the weight of the fetuses, the mean weight was 1.2. Of course, this is a percutaneous approach. We've never exposed the uterus. We do everything under ultrasound guidance, and of course we use systems, those and coronary catheters. There's this very good coronary catheter coming from Europe, from Biotronic. They are very compliant and can be inflatable up to 4.5 millimeter. We learned that with the Boston experience. A quick word on atrial septostomy for established hypoplasts with intact interatrial septum. Although all the procedures were successful to create holes within the septum, all patients died pre or in the post technique. I'm not sure if Wayne about the Boston experience with some stents. I know Toronto has a similar experience, and I think we should do these a little bit earlier, because if we do earlier than 30 weeks using balloons, the holes will close off. And probably these patients died of severe pulmonary hypertension due to arterialization of the veins, of the pulmonary veins. This was a specimen that was taken from one of our patients after the gland procedure. And if you look at the registry, the international registry, in terms of survival, there were no differences whatsoever in terms in patients who underwent atrial septostomies and those patients who did not. So Anita could also comment on that afterwards. So I'm gonna go. Of course, these patients, this disease has a very broad spectrum, and it is estimated that the rate of survival and achievement of biventricular circulations are not very high. So our goals here are improve the chances of survival and to achieve our circulation. We have to have a small right ventricle, probably larger than the Z value of larger than -3, especially the length of the RV with no major sinusoids. There should be membranous atresia and a patent infundibulum. We also do patients with critical AS, some patients with critical AS and small RV, they behave very similar to patients with pulmonary atresia. There should be ductal flow reversal, as you can see here. And some patients had a monophasic filling of the right ventricle. Some patients, of course, most patients have, almost all, to be honest, high RV pressures, and some have reverse venous ductal flow. Our institutional philosophy is the following one. The rehabilitation of the right ventricle is a continuous process in which the first step is the fetal pulmonary valvuloplasty. We've been opening those valves in the neonatal period, so why not earlier? So the sooner, the better. And we believe that it continues after birth and requires some time and patience, as we're going to see. So we use a balloon that is about 20 to 30% larger than the pulmonary valve annulus. When we have pulmonary atresia, Fabio with his needle perforates the pulmonary valve, and this is a very risk maneuver because we can perforate the roof of the main pulmonary trunk. We can see that the balloon is inflated across the pulmonary valve, and we can see some pulmonary insufficiency here, which is a marker of efficacy. When there is significant pulmonary insufficiency and pulmonary and TR, then the fetus can run the risk of circular shunt, as we're going to see. Most of these patients have pericardial effusion. We have to be prepared to drain, especially the procedures that involve the ventricles, both the left ventricle and the right ventricle. And this is a slide showing an example of in neutral progression with some flow entering the right ventricle and some improvement of the RV size at 34 weeks. We place a lot of emphasis on repeat valvuloplasty in the neonatal period, and most of these patients receive a ductal stenting no larger than 3.5 millimeters in the neonatal period. Some examples of evolution, of postnatal evolution. So this patient that had been showed previously at 8 months of age had patent RVOT, and there is a small shunt across the ductus, left to right shunt. And this is at 1 year and 8 months with improvement of the right ventricular size. As you can see here, some left to right shunting, the tricuspid valve almost the same size of the mitral valve. And this is the final result at 3 years with the spontaneous closure of the ductal stent. We studied our 17 first patients, and we came up with these graphs. There is a significant improvement of the tricuspid valve Z value, as you can see here, both from the procedure to birth and then after birth as well. This is the improvement of the RV length Z value, as you can see here, and there was no significant difference in terms of the pulmonary valve Z value. This is a busy slide, but I'm going to take you through it. And we did these 43 procedures in 40 patients. Most had pulmonary atresia. In those patients, we had 4 failures, 3 were repeated, and all patients with critical PS, we had success. In terms of mortality, we had 3 deaths related to the procedure. 2 further patients died in neutral because with circular shunt, both had severe TR. In retrospect, I think we should not, we shouldn't have opened the valve. And we also had 3 neonatal deaths, and these occurring outside of our hospital. In terms of postnatal management, in 27 survivals, right? They achieved the biventricular circulation doing pulmonary valvuloplasty alone as a neonate. Most of patients required ductal stenting in addition to the valvuloplasty. 2 further patients required some work in the tricuspid valve at 6 months of age, and 1 patient required ductal stent closure due to overcirculation after 2 to 3 weeks of the procedure. And 1 patient underwent a BT shunt because of univentricular status, and this patient now has a Fontaine circulation. So in the end, 4 babies are still in neutral. With regards to our 27 patients, 1 had 1.5 ventricle repair, 1 univentricular repair, and most had biventricular repair. Most patients had critical PS, but also some patients had pulmonary atresia and IVS. We didn't have any deaths in our center. And in terms of survival rate, this is the final rate that we have, 77%, with most patients achieving biventricular circulation. So let's change gears now. We're going to talk about fetal aortic valvuloplasty. The goals here is to abort the progression of LV hypoplasia in fetal critical AS, achieving better survival and biventricular circulation rates. So this is the signs of impending hypoplastic left heart syndrome in patients with fetal critical AS. This was published by the Boston group. I think everybody's familiar that when we have flow reversal in aortic arch, left to right interatrial shunting, a monophasic pattern across the mitral valve, and LV dysfunction, these patients will probably develop hypoplasty in neutral. So what about our policy? We think that ventricular rehabilitation is a staged process. It begins in neutral, and we employ a bridge in the neonatal period, and the whole process is finished at the end of the first year of life, so to say. In terms of the neonatal period, we employ the hybrid strategy a lot. We don't have very good results with the Norwood procedure, at least in our center. These patients also sometimes undergo a neonatal aortic valvuloplasty, and sometimes we have to open up the interatrial septum, creating sort of 4 millimeter ASD to prevent pulmonary venous congestion. And if the LV improves at 9 to 12 months, we take down the hybrid procedure. We do some work resecting the EFE. The surgeon does some plasty, some thinning of the aortic valve, and we leave a pop-off ASD. When the patient has mitral valve disease, this can be a limiting factor. What about the spectrum of fetal AS in utero? Most of patients have this pattern here with dilate left ventricle as some EFE. We do some cases, as you're going to see, in patients with smaller LV, with the hope that we can provide, not only we can revert the progression, but we can provide antegrade coronary flow because we do the hybrid. We don't do the Norwoods at our center. And some patients we're going to see had severe MR with gigantic left atrium. So we did 45 procedures in 43 patients, some with LV hypoplasia, some with MR and gigantic LA. Most patients had the classic impending hypoplastic left heart syndrome. We had 3 intrauterine deaths related to the procedure, and we had 2 failures, and both were repeated. So I'm going to show some examples. This is a good biventricular outcome after fetal and neonatal valvulopathy. This is the fetal appearance of the left ventricle, and after fetal intervention and some neonatal intervention, this was the final result. The LV improved, still in utero at 36 weeks of gestation. And this is another example. We showed this case as an edit case at CSI a couple of years ago, and this was the final result with neonatal valvuloplasty at the age of 25 days. Another example, I'm going to talk about stage rehabilitation of the left ventricle after fetal aortic valvuloplasty and a neonatal hybrid. So this was the appearance of the left ventricle pre and post fetal intervention. We did a neonatal valvuloplasty. We did the hybrid procedure, and we opened up a little hole across the intra-atrial septum. This patient had means to go to Boston. So these pictures are from the Boston Children's Hospital. I think Lisa did this cath, and we can see the stand here nicely positioned. We can see the PA bands here. You can see the size of the left ventricle here. We put a lot of emphasis on the left ventricular and diastolic pressures to create an ASD. And of course, these patients had an MRI as well. You can appreciate the degree of the FE here. And so Dr. Deonido took off this a big chunk of FE, and this was the final result. This is Saldiva's pictures, the PE, a very nice contracting left ventricle, a little hole across the septum, and a nice appearance of the aortic valve after some cleaning. So this is another example after 2 fetal aortic valvuloplasty, and this is the appearance at the age of 2 months with some EFE, and this was the final result after a Ross procedure and a mitral valvoplasty at the age of 8 months. I think this is a candidate for mitral valve replacement. You can see that the mitral valve doesn't.
Carlos, could you check your audio, please?
Yeah, is it better now?
Yes, we missed the last slide. If you could go back to the one before, please.
Yeah, well, just a picture to show that the mitral valve didn't look that good. Anyways, another example, this was done in a smaller left ventricle. We did the procedure. You can see the left ventricle here with lots of EFE 2 weeks after the procedure down here. And we also use the strategy that was postulated by Dr. Kohl in Germany. The mom had some hyperoxygenation to improve pulmonary flow and to improve the pulmonary venous return to stimulate the left ventricle. And this is the evolution after when the kid was born, 5 months after the hybrid procedure. So at the age of 9 months, we also capped this baby. Left ventricular diastolic pressure was 12, so not that bad. We did also MRI. The LV had good volumes, and this is the final result after surgery And this is the picture when the kid was 2.5 years, and now he's 7 years and doing very well. And another example, when in patients with severe MR and gigantic left atrium, so this is the needle entering the left ventricle, the balloon was placed across. He had an improvement in his herb. In fact, he dropsies and had an emergent atrocetostomy after she was born. This is the ASD. This is the appearance of the left ventricle after the hybrid procedure. Again, MRI for volumes quantification. Again, a cath, we can see the bands here, very nicely placed bands. We can see the left ventricle. The forward flow is almost exclusively coming from the left ventricle, of course, is very hypertrophied. And this is the appearance, final appearance after biventricular repair at 10 months. This is the appearance of the left ventricle. Her name is Victoria, by the way. So this is again a busy procedure. It's a summary of our outcomes, focusing on mortality rates. These are the numbers. We had 3 deaths in utero, 1 termination. And we had 16 postnatal deaths. So the attrition is very significant in terms of procedures and deaths. Some patients died prior to any kind of procedure, some post-hybrid, some after an intent of biventricular repair, some after a univentricular repair. So in the end, we have about 50% of survival rate. And among those survivals, most had a final biventricular circulation. 73% of the survivors and 37% of the total cohort. However, 1 patient was listed for transplant because of severe diastolic dysfunction and asynchrony. So these were the procedures that were implied in those survivals: sole neonatal valvulopathy, ROS, and 7 underwent staged rehabilitation of the left ventricle. So in conclusion, talking about an overall summary, these interventions were feasible in our hands. I didn't show here, but we didn't experience a real learning curve, probably because Wayne and Gerald taught us very well. In fact, again, I thank Wayne because he and Audrey gave us a lot of tips to do how to do that. We are fortunate to have Fabio as a very skilled perinatologist. He does all kinds of interventions. I think our complication rates are acceptable. There were no maternal complications. Our rate of fetal demise is okay vis-a-vis with the rate of the international registry. For pulmonary valvulopathy, we think this is a technically challenging procedure. It is way more challenging than the aortic valve, but it results in the most rewarding long-term outcomes, especially with regards to biventricular circulation. Of course, providing that the proper strategy is employed in the neonatal period. We don't have to worry about ductal stenting. They close spontaneously during the follow-up, and some patients require some tricuspid repair. As for the aortic valvulopathy in the fetal life, is much easier from the technical standpoint. I think we are dealing with a higher risk population in our cohort because of late referrals. We also do in those patients with smaller LV. I don't think Boston would do some cases that we did. Maybe Gerald wouldn't either. There is significant mortality rates in our experience. However, the rates of biventricular circulation are really encouraging. And of course, long-term outcomes should be elucidated, especially in terms of late diastolic dysfunction and the need for transplantation. So with that, I finish my talk, and thanks again for your attention and for this kind of invitation.
Thank you so much, Carlos. And we have a few minutes for questions. And since it's a very important topic, I think I will ask the panelists to ask the speaker about what they think, like Anita, Shaq, and Ulrika. Do you have any questions for Carlos?
I have a question, and maybe you covered it and I missed it, but nice to see you, by the way, Carlos.
Good to see you.
Have you, you've been at this for a while now, in your perception, has there been any significant evolution in the actual technical part of the procedure, and where do you think we should be going as far as trying to get the procedure related complications and death rates down? We're consistently seeing and telling patients that there's a 10% fetal loss rate, and that is just unacceptably high for for especially the pulmonary valve patients who may be able to have a 1.5 ventricle repair after birth. So if we could get the fetal mortality down more, I think that there would be more uptake for the procedure. But so it's a kind of a long, complicated question. Has there been any evolution since the first needle went into a fetal heart with a balloon inside of it? And if not, where do you think we should be going?
Anita, you're talking about right heart or left heart or both?
Either one.
Okay.
Yeah, well, I think it doesn't matter, because this is a good question, and I don't think we change our technique over the years. The biotronic balloons profile, we have to push them through 17 gauge Shiba needles, and this is it's very big profile. So I think this is our main limitation. We have a significant rate of pericardial effusion. And we lost 2 patients because we perforated the MPA using that.
We seem to have lost Carlos' sound.
So there was no change in the technique employed, and I don't think we got better over time. I think of course we got more confident. Now we feel at ease to do those procedures. But I think in terms of atrial septostomy, I think the way we're doing it doesn't work. So we should place a stent probably at a younger age, which is very, very difficult. The rate of complications, embolization, failure is significant, even in the best hands. I think in terms of technique, I think this covered all. I don't think we changed that much.
Thank you. Any other questions from the panelists?
Carlos, quick question. Well, it's not quick. One of the problems, of course, with aortic interventions is where you convert a smallish left ventricle, and that's because of the timing of fetal intervention, to a borderline left ventricle by time of birth. And then you're almost committed to going down the route of hybrid, trying to push that ventricle to become a 2-ventricle circulation. And it does for a while. And then the problem arises later on, 5 years down the line, when the ventricle is stiff, raised EDP, pulmonary hypertension. And there we've converted a patient who could have been okay for Norwood into a possible transplant candidate. Any thoughts on how, that type of patient?
Yeah, that's a very good question. It involves philosophy as well, because some patients might benefit from a good univentricular repair. They benefit more from this approach to a so-so biventricular repair. We chase biventricular repair here. I think our patients do better in our hands. The univentricular pathway, especially the long-term outcomes are not that great. So, but there's a price to pay, and I agree with you, and I don't know the answer. We have a patient that has been in hospital for maybe 4 months. Simone can talk about this patient with very bad LV diastolic dysfunction. So I don't know, Shaq. I think this is something that we have to study. I think maybe Boston, they've been doing that for over 20 years now. I think Wayne has the answer, probably. I hope.
Yes.
Wayne, can you comment, please?
Well, I think that it is, you know, the postnatal management is in a way completely separate from the fetal procedure, in the sense that once the baby's born, you have to make the clinical decisions for the baby that's best for the baby, not just because he had a fetal intervention to wish the baby to have a biventricular circulation. And for sure, you know, we've made those errors as well, as everybody has in understanding the modification of this disease. And so, you know, I think, again, you have to use the best criteria, you know, in the way you manage patients. I think it's a long and complicated topic, as Shaq outlined. I think we could even do a whole session on borderline ventricles in this forum, because I think it is an evolving, developing topic in itself. And the problem is there's no easy answer. So it's not something that there's going to be a magical answer, but I think it is actually worth, you know, having some of our surgeons and imaging colleagues and talking about this more in general terms, because there have been some interesting developments in this field in general.
Thank you. We have a question from the audience. Do you have any data for the gestational age of delivery after intervention?
Well, I mean, almost all those patients, we try to deliver them at our center. Sometimes it's not possible because they come from different parts of the country. We do that on an elective basis. We do a C-section at proper times. Of course, we know that these patients, these fetuses, can be delivered by vaginal deliveries, but because of the logistics at our center, we try to do a C-section between 38, 39 weeks of gestation. I know Simone is here. She could comment also, because she's the head of this program, and she could say some words on that.
Simone, could you comment, please? That would be great if you are on board.
Hello, nice to see you all. So regarding the gestational age, we usually wait for term after 38 weeks, and we didn't have any preterm delivery because of the procedure. So it's not usually not necessary, and we didn't have premature labor because of the procedure. So of them, 38, 39 weeks gestation.
But all cesarean, right? All should go through cesarean section.
At our center, yes, because we don't have a delivery, vaginal delivery unit. We don't have OB 24 hours, 7 days. That's why, but we don't have preterm deliveries because of the procedure. We didn't see that in this cohort.
Do the obstetricians put them on anything to keep to avoid preterm labor, or they just leave them alone?
Never.
Never. Great. Thank you very much.
Rima,
Sure.
Rima,
Yeah.
there's a quick question, which is an easy one for Carlos, I've spotted from the audience.
Yes, please.
It says, it's from Marwa Qasim. How does the cardiologist overcome the fetal movement during intrauterine catheterization? I thought it was an easy one for Carlos rather than the earlier questions.
Yeah, well, after maternal anesthesia, we do a spinal maternal anesthesia, sometimes with sedation, and Fabio goes there and change the position of the baby. Once a nice position is achieved, then we give a shot, sometimes intramuscularly, of fentanyl, atropine, and paralysant, some succinylcholine as well, succinyl, whatever, pancoronial, sorry.
So the idea is just you want to keep the fetus still so that you can target the heart. So to summarize it, you give intravascular injection in the thigh, and the hope the baby the fetus will stay in the same position. We have to move to the next speaker, please. And I'm very delighted to introduce Wayne Trusky, who's going to talk about himself, introduce himself. Wayne.
All right, can you see my slides?
Yes.
Okay. Oh, hello everyone. Shaq and Ulrika, nice to see you as well. And I'm going to talk about some of our experience at Boston Children's Hospital. I work at Boston Children's Hospital, and we work very closely with our colleagues at Brigham and Women's Hospital. That's our obstetric hospital next door. That's where the procedures are performed. Obviously, this is a very, very large topic, and I'm not going to cover everything. We could do other sessions and have other colleagues of mine talk about other things at a different time, because there's no ways we'll cover everything.
Wayne, we're seeing presenter view.
Oh, so now what am I?
Full screen, full screen.
Oh, I did that, but let me switch.
Up there, yeah.
Swap this one.
I think I can see it. Yeah, I think so. Yeah.
Yes, that's right. That's
yes.
Is that good? Yeah.
That's
yeah. Click.
Is that good? What are you seeing now? Are you seeing full screen?
No.
Oh, still the same.
Try and do it again. Yeah,
So,
I know.
Let me just stop sharing.
Yeah. Now, yeah. Okay.
Let me just see which.
You need to buy an expensive computer, Wayne.
I think I do. It's right. It's we've had some budget cuts here, so let's see if I can go back to here, and let's see, share screen, and there, and then go to. How does that look?
Yeah. No.
It's still the same. Okay. Now if I do.
Yeah.
That.
Click there. Yeah. Okay.
Yeah.
Okay.
All right. So I'm going to talk a little bit about the timeline of our program. I'll talk about aortic stenosis, and then there will, of course, be some overlap with what Carlos spoke about. And then I'm going to talk about Epstein anomaly, and the other topics we can add maybe at another session, but Carlos did touch on them, but there won't be time now, obviously. So a little bit of history here, and I'm glad that Shaq Qureshi is here, because the first procedures were done at Guy's Hospital in London in the late 1980s. And I was actually very fortunate, just by chance, to be an SHO in 1991. Shortly after that, that's where I first met Shaq and the rest of the team, Lindsay Allen, Mike Tyner, and Daryl Maxwell. And I thought this was the most amazing thing, I'd ever heard of. And then after that, I moved to San Francisco and did my pediatric and cardiology training under people listed over there. Abe Rudolph, Mike Heyman, Norman Silverman is online and being very quiet. And their surgical team, of course, Thomas Cole. And then after that, moved to Boston, where we started our program here in the year 2000, so just over 20 years ago, with Louise Wilkins, Carol Benson, Stan Perry, Audrey Marshall, and Jim Locke. And now the team has morphed as people have moved to other things. Our main cath people, Ryan Callan and Diego Porras, and still some of the obstetric team the same, with some new people. And so, it's been obviously a journey over a few decades, my interest in this. And of course, all the colleagues that are on this call where we've shared data and learned from each other. And of course, most of all, the patients who have put themselves forward for what were initially experimental procedures and now more and more becoming mainstream, but still, obviously, we have a lot to learn. So in terms of aortic stenosis, there's a pretty well-described natural history. We always have more to learn. But certainly in some of these patients, there is a unique window of opportunity to prevent progression to hypoplastic left heart syndrome. We wish that that was the case in all patients, but that's actually not the case. And one of the challenges we have is to select the patients that are salvageable. Now, the challenge, of course, is that postnatal surgery for HLHS has improved, but the survival in general is still not satisfactory in terms of the longer term outcome. And of course, we don't really know about the multi-decade outcome, but certainly some data from our institution, it's not published yet, but around 18 years of age is between 50 and 55% survival for hypoplastic left heart syndrome. And obviously, longer than that, we don't really know. There are not that many survivors in their 30s and 40s, certainly not in their 40s. And as we know, there are long-term issues and the need eventually for heart transplant in HLHS. So our first procedure was attempted in March of 2000 and was unsuccessful. That patient went on expectedly to have hypoplastic left heart syndrome and now has a Fontan and is actually doing quite well. Our first successful procedure was 18 months later in September of 2001. That patient, we may have just got lucky with our second procedure, and that baby, that child has done very, very well. And all he's had is 2 postnatal balloon dilations over the years. And overall, we've performed 240, probably close to 250 now, interventions over the last 20 years. We peaked at 24 a year, and then other institutions started doing some in the USA. And we're currently doing about 1 a month. That's the current volume that we're doing. And our fetal aortic stenosis procedure is actually now closer to 170. Now, the reason we're here in this forum is actually more to have a discussion rather than didactic. So I think some of those questions are really good, and it's we can continue the conversation and the disagreement and discussion. But these are still the comments that we get when we present, and from our colleagues, challenging us, which they should. Some people say things like, "I don't believe in fetal cardiac intervention." Well, that's fine. Are you still doing that? Well, clearly we still are, because we're here presenting our data. Why don't you just balloon the valve after birth? And that's a common question. One has to understand the natural history in utero to answer that. What are the criteria for fetal cardiac intervention? And that's also not, as much as it would be great if there was a simple answer to that, it's actually a little more complicated. And how do you define success? And there you're talking about technical success and postnatal sort of biologic and circulation outcome success. And that's also, on the one hand, simple if the patient does spectacularly well. And then obviously there's a lot more details into that. It's important to know that not all aortic stenosis patients evolve into HLHS. There are some that are very mild, but the vast majority that you're going to detect in utero, and the reason they get detected is because the ventricle is dilated, echogenic, dysfunctional, and those are the ones that will develop HLHS. The ones that are very mild actually very rarely get detected in utero. And this figure sort of demonstrates what I'm talking about, that if at 20 weeks you have very mild aortic stenosis, by the time of birth, you could have neonatal critical AS. If you have severe aortic stenosis with its effects on the heart in early gestation, for sure you're going to have hypoplastic left heart at birth. And in the middle, of course, is the so-called borderline left heart, which is always very complicated to manage. I'll show you some clinical examples. These are our first 2 patients, actually. So this is the very first, this is Echo at 19 years of age, and our very first unsuccessful attempt at a fetal intervention. And as you can tell, the patient has hypoplastic left heart. This was our first successful one. And you can tell the patient has a well-functioning 2-ventricle heart. Now, you're probably thinking to yourself, well, there's no ways these patients were the same. And I'll show you what their fetal echoes looked like way back. So this is the one that was unsuccessful. You can see the dilated, this is at probably around 23 weeks or so, the dilated dysfunctional left ventricle. And this is the one that we ended up doing a successful procedure on. Again, the same dilated dysfunctional ventricle, even with some spots of EFV. You can tell this is digitized videotape from a long time ago. So these patients were quite similar in mid-gestation. I'm going to show you what I would call our ideal type of patient, because Carlos did show some examples of patients which, again, were very challenging, and maybe, as we've done, patients whose hearts are actually not salvageable anymore because there's already too much damage. So this is a case of a patient that was first seen at 22 weeks. And you can see there's a nice broad jet of flow with some stenosis across the aortic valve. And the 4-chamber view here shows still relatively preserved left ventricular function, but there is already some mitral valve regurgitation here. And I'm going to use this cool feature of the laser pointer. And the feature didn't work very well. All right. So, and here you can see the left ventricular systolic function in the short axis is still okay, and there's antegrade flow around the aortic arch. And so that was 22 weeks. At 25 weeks, so you have to follow these patients weekly once you make the diagnosis, or at least every 2 weeks. You can see 3 weeks later, there is a moderate to severely dilated left ventricle with severe left ventricular dysfunction. And just to show you the comparison, 3 weeks earlier, the ventricle looked relatively normal. And the other changes that occurred, there was now retrograde flow in the aortic arch and fused mitral inflow. And so this patient indeed came to us for a fetal intervention in a timely fashion, because the minute things started to change, we knew that they were going to continue to get worse. The technique is the same that Carlos outlines, and really the technique of using the needle, the wire, the balloon has not changed that much. I think in terms of just the general experience of the team and patients, not making some of the mistakes we made before has led to increasing technical success. And again, you can see wire and balloon inflated across the valve. That's going to look the same in all of these. And this is now probably a week or two post the intervention. You can see the ventricle has shrunk back to its former self with improved function. This is what it looked like before, and with a nice broad jet of flow across the aortic valve, and most importantly, antegrade flow around the aortic arch. And this patient actually ended up doing very well. Was born at term and had nothing more than a postnatal balloon dilation. I don't believe he's had anything else since then. And this is the ideal patient where you can actually watch it in evolution, and you want to not wait too long before you intervene in these patients. I think many of the patients that we've done historically are too far advanced. And, you know, I think the important lessons that we've learned, teamwork obviously is important, working together with obstetricians, anesthesia, cath people, imaging people, nursing staff, etc. I think that in some cases, I think we've done ourselves a service by, if the baby's not in perfect position, to leave the mother lying on her side for a few hours and come back instead of trying when the position is suboptimal. I think with some of our early failures where we tried the procedure when the fetal position wasn't optimal. And sometimes we've had to, you know, try again the next day. Certainly the first left ventricular puncture gives the best shot at this, because once you have to do multiple LV punctures, you start to introduce air and potential for thrombus, and the imaging can deteriorate. Fetal resuscitation is an important thing. Bradycardia is not uncommon, occurs in about 30 to 40% of our cases, and we treat that early with intracardiac epinephrine, and occasionally we'll need to drain a hemopericardium as well. The balloons can be oversized, just like with the postnatal pulmonary valve dilation. We've published several papers on our results, and we're working on updating our data with more recent numbers. But this one from a few years ago, with Kevin Friedman as the first author, showing our changes in technical success. So as you can see, the darker bars here were successful ones, meaning the procedure itself was technically successful. We opened the valve. You can see that we failed quite a bit, probably 25% of the time. Certainly in the latter half of our experience, and this continues to improve, very few technical failures. And the same with the proportion of patients that are biventricular. In our initial experience, the majority were still ending up as hypoplastic left heart, probably based on the fact that patient selection wasn't correct at that time, that the patients were probably already too far advanced. And more recently, and this bar continues to grow in comparison, in the sense that a high proportion are now biventricular, based again on more technical success, plus our understanding of the disease and better patient selection. There are many factors that we look at in choosing these patients. I think left ventricular pressure is an important one. It's not everything, but it is an important one. And you can estimate left ventricular pressure using the mitral regurgitation jet or the aortic stenosis jet. And certainly the higher the pressure, the better. Similarly, things like left ventricular sphericity. So the more pathologic changes, the more globular the ventricle is, probably the less likely it is to recover. If you look at this kind of patient here, where you can see a very globular ventricle with EFE, here's the right ventricle pancaked by the left ventricle. And in this case, despite a successful intervention technically, here's the right ventricle and the left ventricle just shrunk and was encased in EFE. So why do we fail in some cases? Well, fail meaning why does the patient not have two ventricles? That's the desired outcome. I'd say most of them really are because the patient gets referred to us too late. And obviously in some cases we just won't do the procedure because we think it's futile. I think it really will be a continuing education for us in terms of learning how to select patients. There's no real one magic number. We still occasionally will have procedural failure. And I think a very important thing is non-uniform postnatal management. And that, again, is obviously logistics. And some patients just cannot come back to us for delivery. And obviously, suboptimal decision-making, again, probably a topic for another day, because this is way too complicated on how we make the decisions, the management decisions postnatally, which in itself is quite complicated. And obviously, we'll continue to do research as we are. We have a whole bunch of papers in production now looking at our data. And I think a very important part of this is our surgeons are very enthusiastically looking at different ways to help these ventricles after birth. So I'm going to move on now to Epstein anomaly. And another, difficult and a very complicated fetal disease, certainly not the mild form, but the severe form. And you can see here the dilated right atrium, the typical fetal Epstein's with the displaced septal leaflet, and the severe tricuspid valve regurgitation. So this is a pretty challenging lesion that has a high perinatal mortality. The critical period for these patients is usually sort of after 30 weeks to about a month of age, when they can get into trouble in utero, but also they my automatic light just went out, and then and as you all know, have taken care of fetal Epstein neonates. It's a very challenging problem to deal with. And these patients do, in some cases, have potential for biventricular circulation, not necessarily at birth, maybe later. And of course, if they need a Fontan, they are patients that, in theory, would be better because they do have a morphologic left ventricle. Now, there are many risk factors for Epstein anomaly. Why they do poorly? They're often born prematurely because the fetus gets sick. They have hypoplastic and compressed lungs. They have low right ventricular pressure. The ductus can hurt you in this case, and pulmonary regurgitation in particular when you develop a circular shunt. They often will have a thin-walled myopathic right ventricle, and they have low cardiac output because the left heart has decreased preload. And this is an image of a Epstein's fetus that has pulmonary regurgitation. So when you see your next patient, make sure that you see flow either antegrade or retrograde across the pulmonary valve. So pay attention to that. It's not something that's obvious. You have to specifically look for it. So the problem with Epstein anomaly, again, is that they get low cardiac output because they have small lungs, decreased, of course, pulmonary venous return because of the low pulmonary blood flow, and then the left heart compressed by the right heart. You also get distortion of the foramen ovale with reduced left heart preload. And then when things get really bad is when you have left-right flow down your ductus, and more importantly, pulmonary valve regurgitation, where there is significant steal from the systemic circulation. So even when you're measuring cardiac output at the aortic valve here, much of that gets stolen down the duct and down the pulmonary valve. And so you get this cascade of fetal acidosis and potentially either fetal demise or prematurity. So why are we talking about this? Well, the question is, what can we do about this? And so for the past almost decade or so, and it's obviously a very rare lesion, this, we have in selected cases been treating this with non-steroidal anti-inflammatory drugs. So ibuprofen, indomethacin. And that is something that, as you know, is usually contraindicated in pregnancy because it causes ductal constriction. But in this case, the duct is hurting you because it's left to right. And so if one can constrict the duct, can we reduce the steal from the systemic circulation? This paper by Lindsay Freud, a multi-center study from 23 centers, published in 2015, looking at a large series of fetuses with Epstein anomaly. And you can see we started out with 243 fetuses, and the overall survival when you ultimately, after fetal demise and postnatal therapy, only about half of the patients actually survived to neonatal discharge. And obviously there's a lot of data in this paper, but one of the risk factors for these patients is pulmonary regurgitation. And so I'll just show some examples of treating these patients. So we're basically using the side effect of a non-steroidal anti-inflammatory drugs as a therapeutic effect when the duct is stealing from the systemic circulation. So this is, I'll just show some brief slides from a patient. This is a Epstein's patient that had hydrops and sort of pre-morbid signs in the umbilical vein and had absent diastolic flow in the middle cerebral artery Doppler. And then this is, I know these pictures are fuzzy, but this is a fetal Epstein's, and this is the pulmonary regurgitation. So we administered indomethacin to the mother, and the hydrops cleared. We got ductal constriction. And by, that was at 27 weeks when we first saw, and at 36 weeks, you can see this tiny constricted duct here, but robust flow in the aorta. The hydrops went away. And in fact, there was then also more robust flow in the brain. So the baby was born at 36 weeks, was quite small, 2 kilos, was blue with obviously very low pulmonary blood flow. And unfortunately, we tried to do a Stans procedure on the baby and ended up on ECMO and ended up not surviving. But we did learn something about potentially changing the physiology in utero, and we knew we would be getting another patient soon. And so this is another patient that came around 28 weeks. Again, you can see the very large heart and the flow reversal in the duct and the pulmonary regurgitation. And this time we didn't wait for the baby to get sick. We treated earlier, got some ductal constriction on this patient, got all the way to term. You can see in late gestation, there's a small amount of regurgitation here with ductal constriction. The typical X-ray that you see in these patients at birth, the wall-to-wall heart. And this patient was very, very sick in utero, in the newborn period. It was on high-5 ventilation and nitric oxide, etc. You can see there's some ductal constriction still in the background, still some pulmonary regurg. But as the pulmonary vascular resistance dropped and we let the duct close, the baby's right ventricle started to eject antegrade. And you can see here, once the duct closed and the pulmonary vascular resistance dropped, baby, without any surgery, was able to eject antegrade. And at discharge, this is what the X-ray looked like. You can see the tethered septal leaflet. And this patient, in the end, had a cone procedure at about 3 years of age. So we put together a series of these we collected a series from multiple centers, including Simone Pedro's on the call here. Essentially, you know, it was a very small trial in this very sick group of patients. And what we had 21 patients total that at least were inquired about this. Some of them declined. They went into the group that didn't get ductal constriction. Even those that we did administer the medication to did not get ductal constriction, because not all the patients do achieve ductal constriction. And when you compare those that did not and did, have ductal constriction, those that did get ductal constriction had a higher proportion that were live born. Remember, this is a very, very sick cohort of fetuses. The other interesting thing is the median gestational age at birth was 3 weeks greater in those that got ductal constriction. So I think we learned something about this. One of the risks here is oligohydramnios, where we do have to stop the medication for a few days sometimes to let the fluid reaccumulate. So it's, again, a more complicated story. But we did show that the non-steroidals can mitigate the circular shunt in utero by ductal constriction. There's potential for a bigger and more mature baby at birth that will need surgery. The group in Toronto have also published on this recently. So I think there's potential in this, but it has to be investigated further, and we are in the process of starting a prospective study on this. Again, I'd like to thank all my colleagues that I work with every day, our obstetric group at Brigham and Women's Hospital, my cath colleagues, my anesthesia colleagues, and of course, all my nursing and administrative and echo staff. So, and of course, all my mentors over the years, starting with Shek Qureshi when I was at Guy's Hospital in 1991, and then Norman Silverman in San Francisco, who are on the call here, and of course, many others. So thank you, and I'm happy to take any questions.
Thank you, Wayne. Beautiful presentation as usual. And I'd like to open the floor for a few questions, but from the panelists first, and then we go to our beloved audience. Anyone from the panelists would like to ask Wayne any question, please?
Rima, if I could just ask a question, and I was then going to try and bring Norman in because he's keeping very quiet. So Wayne, excellent talk as usual, and some fascinating data. One of the issues when you apply the technology around the world, in countries, Asia, Far East, where the Norwood program is either not very good, mortality is high, and therefore nearly non-existent, you could probably push and justify fetal interventions, especially for aortic stenosis, for example. In other countries where the Norwood survival now is really, really good, that's where the moral dilemma arises. And in UK, for example, when we give the parents our Norwood survival and then offer them fetal intervention, majority of them in the last few years have gone or opted for the progression of pregnancy and then going down the route of Norwood program. And so the fetal cardiac intervention numbers have been really very low. Any comments about the different parts of the world? And if we could pick on Norman afterwards as well.
Yeah, I mean, I think this is a problem. Obviously, it applies to so much in what we do in congenital heart disease and healthcare in general. There's no easy answer to this because it's about resource utilization, and obviously there are some situations where there is nothing that can be done. So I think if it's something, it may be easier to do a percutaneous ultrasound guided fetal intervention with a needle and a balloon and an ultrasound machine than and potentially make the patient better than obviously spending months in the hospital. But again, every situation, every patient is different, and you have to have the facility for all of those. So it is it's sort of an unanswerable question, unfortunately. But yes, it's a challenge that we face with everything that we do.
So maybe the message will be, depending on the center where you're practicing, depending on the resources, you can make the decision depending on how good your surgeon is. Maybe in some centers you have interventional who are better than the surgeons. So could you make it like a flexible answer?
Exactly. I think that's right. I think you have to take it as on a case-by-case basis, really.
I think Carlos wants to answer it as well.
Including me.
Sure.
And Norman, yes.
Yeah, I mean, I think that this is a very complicated issue. And my experience with underdeveloped countries largely is in South Africa, where I've been at the University of Cape Town, Wayne's old stomping ground. And there, the issue is, do you devote your resources to treating hypoplastic left heart syndrome or Epstein's malformation, or do you devote your resources to treating VSDs and patent ductus arteriosus? So I think it's a very complicated question. Certainly in the underdeveloped world, the resource issue is so critical that I think that these patients just get overlooked because they have to be overlooked.
But the question that Jack asked is the technicalities, and for you as a morphologist, do you think this will change the outcome if we do in utero? And as Wayne said, we catch them early, the ventricular remodeling will be there. So is it like a clear-cut answer to that? That, okay, it's a very good thing. Suppose we have the resources, well, and I'm a patient, I have to choose one of the two, both are available. Dr. Silverman, as a morphologist, what do you think? Should we do it? Should we wait? Depends on the patient gestation and a lot of selection criteria. Now, I think genetics should come on board when we're doing this. What do you think? This is Dr. Qureshi is trying to ask this in an indirect way.
Yeah, I mean, I think that we do not change the morphology substantially. We can open a valve, and that may change the issues. But I think that the postnatal opportunities for surgical intervention have changed my thought processes on a number of these lesions. I think that endocardial stripping, which actually we've done a number of them at Stanford and UCSF, have worked out to be quite remarkable. I mean, when you do this procedure, the surgeons get into a plane, they can remove the fibrotic endocardium without actually damaging most of the underlying ventricle. And then it's a question of physiology, because once you've removed this resistant chamber to both filling and emptying, the ventricle's performance is increased, and also by a small amount, the volume of the ventricle is increased. So instead of contracting from X, it's contracting by X plus a small number, which makes it much easier for the ventricle to perform well. The other thing that has really sobered me recently is to look at the results of the cone procedure. I think when you look at the cone procedure, what it's done, it's really radically changed the potential for survival and good survival for a number of these patients with Epstein's malformation. And I mean, centers that have a lot of experience, like Wayne Center and University of Pittsburgh, where Dr. De Silva, the cone founder, is working, are really quite remarkable. And even the conversion from Stahn's procedures earlier on to other procedures later on has improved the quality of the survival in these patients unquestionably.
So do I have a question? We have a question regarding the ductal closure. What is the gestation that you would like to start the non-steroidal, and how often you give it and what's the dose? And would you continue to delivery?
Well, patients who have pulmonary regurgitation very early in gestation may not actually survive, too late in gestation. I think what is more typical in these patients, they start out with antegrade flow early on, and then you get ductal reversal, and then you get pulmonary regurgitation. So most of the patients that you're going to see is going to be in sort of the late 20s, I'd say 26 weeks onwards. So I think most of the ones that I've personally been involved with have been started around somewhere between 27 and 32 weeks. What we do is we start out with, and remember, this is still experimental. This is not stuff that, I'm saying this is what we personally have done, is endomethacin. Obviously, the mother has to have no contraindications, and we give between 300 and 400 milligrams a day, so 100 TID or QID, depending again on the gestational age, and we do that for about 48 hours. Then if we get ductal constriction, then we switch to ibuprofen 400 4 times a day. because that has less toxicity to the fetal kidney and probably to the mother as well. For sure, you have to watch these patients very closely. If there's oligohydramnios, obviously any side effects to the mother, then we would stop for a few days, let the fluid recover, and then we usually would stop it a few days before delivery. Obviously, it has an antiplatelet effect, which is important. We'd also want some of the, and if you're getting close to term anyway, so that would be a good thing. But yes, we would stop it probably a few days before delivery. It's again, this is still evolving, this management.
Would you, I mean, why did you choose indomethacin and then switch to ibuprofen?
Well, there was some experience with indomethacin. Maybe Anita can talk about this, and Norman from the fetal surgery literature, that they were giving it to suppress labor in those patients that had had uterine incisions. And I remember when I was a fellow, Norman was supposed to go up and scan these patients every day for ductal constriction, but he sent me up there to scan the patients instead. And so I got a lot of experience actually scanning these patients and learned a bit. And these patients would indeed get ductal constriction, and then they would have to modify their dose and then go back on again if they started contracting. And so I think that's sort of where we initially got that from. Maybe Anita can comment on how it's used in the fetal surgery realm.
Anita?
Well, yes, indomethacin is kind of standard for open fetal surgery. We had the mom's trial patients all received peri-operative indomethacin, and Wayne is right. They all get ductal constriction, even at gestational ages younger than what you might expect, 21, 22 weeks. So, and that it takes about 48 hours in those patients. But, you know, indomethacin also constricts the renal vessels and so it's non-specific, right? And I'm concerned about brain perfusion in a hydropic fetus who probably already has issues with oxygen delivery to the developing brain, and then to give this indomethacin and continued NSAIDs for constriction. Wayne, do you have any data on whether this is also affecting brain perfusion? And is that a consideration or anything that you discuss with the mothers before you give the drug?
Yes. Well, of course, in theory, if you constrict the duct, you're going to reduce your steal and improve brain perfusion, because in fact, that's what we have seen in these patients is you actually go from absent diastolic flow in the MCA Doppler, where you actually get then, once you constrict the duct, you get more flow. Now, in terms of the effect on the actual brain perfusion, I can't tell you, and we don't have, you know, we actually have very few survivors in this whole group anyway, and so we don't have long-term neurodevelopmental outcome, but I certainly have a few patients that have done very well, but that's anecdotal. But yeah, those are, you know, it's a point taken, important. Anytime we do something like this, we have to be concerned about the negative effects, obviously, too.
Carlos wanted to say something as well.
Yeah, please, Carlos.
Yeah, just a quick question. Wayne, what would be the minimal age, gestational age to do fetal aortic valvuloplasty because of some technical limitations, and any advantage of gearing towards an earlier age? Because from the technical standpoint, because we use these needles, it's one limitation, going back to Anita's question. And I agree with you that the first shot is the most important one, because these ventricles, they shrink and you can't see a thing, especially under 24 weeks of gestation. And what would be the upper limit of gestation and age vis-a-vis with the point of no return?
I mean, you know, I think it depends on obviously the size of the fetus, and then it also depends on the disease progression, like where it is in the disease. The youngest we've done is 19 weeks, but that's only one. Yeah, we've done a whole bunch between, say, 20 and 25. Probably the majority have been that. And then, of course, some of them just come to us later and are still candidates. So In terms of the upper limit, that's a complicated one. The latest one we've done is 32 weeks. Clearly, if it's a 35, 36 weeker, you probably wouldn't do it in utero, just deliver the baby or wait another week. But there's definitely that intermediate zone where you don't want to deliver a 33, 34 weeker with say severe AS. Would you do it then? We haven't really encountered that situation much, but I think if you're still a candidate, probably at 33, 34 weeks, you could probably scrape another 2 weeks out of it and be okay at birth. So 32, I'd say, is our upper limit, but we certainly haven't done many, maybe two or so at that point. But really, it's mostly about what the patient looks like at the time that you're evaluating them, rather than gestational age.
Going back to the question that Dr. Qureshi said, and to you, Carlos and Wayne, remember the hypoplastic left heart with intact atrial septum. In Carlos' data, they all died postnatally. So is the message there, if you have critical AS with intact septum, just leave them alone? Don't send them for intervention? Is this the message from the data that we've seen, or it's not that?
No, but I can answer that. It didn't work in our hands. Of course, there's other issues involved, logistics. I think it depends on your environment. I think other centers can deal with this disease better than us, postnatally, I'm talking about. So I don't think we should stop doing that. But I think we should change the technique. I don't think just ballooning the septum is enough to prevent all those pulmonary abnormalities. So people have talked about ultrasound creation of holes in the interatrial septum, but it never got off the ground. So maybe Wayne can talk about placing stents in the septum. We cannot do that using metallic Shiba needles, where the profile does not allow to do that. But at this, maybe it doesn't work in our hands. We should think about offering this kind of procedure, but I don't think this is should be like a widespread concept.
Did you offer the maternal hyperoxygenation plus the stent, or just the stent?
No, a hyperoxygenation when there's some LV hypoplasia, right? And I think that's the most important indication of maternal hyperoxygenation. I don't think it has to do, we've never done with intact interatrial septum. If I'm not sure, Simone is a better person to answer that, but I don't think so.
Usually it decreases the pulmonary vascular resistance, and if you do the pre and post, you'd find different PIs values in the pulmonary arteries. I think.
Gerald, Rima, Gerald.
Gerald, yeah. Gerald?
Yeah.
Sorry.
Well, I think we're just at the beginning of this atrial septostomies. I think placing a stent is the only way to keep an effective hole open between those two chambers. And there are basically, and I wanted to cover it in my talk that I want to give and give you some examples. There are those who have this intact atrial septum very early on with this severe lung damage. Well, there you need really tiny stents. And I think we're just in the beginning to placing these stents and see what the decompression of the left atrium really could be. We've started this. The procedure basically is not really difficult. It takes 5 to 10 minutes to place the stent, and that's it. And that's the other way, well, to have this severely restrictive foramen ovale or closed atrial septum close to term, and you don't know how to manage the postnatal period, the immediate postnatal period, with an exit procedure, with an emergency cardiac cath, putting child on ECMO and so on. But placing the stent just a few days before delivery, and we've done 2 of these in hypoblast, really gets you out of this. Just placing the stent in a baby at 38 weeks is not a difficult procedure at all. It's quite easy. And it's done instead of an emergency cardiac cath procedure or an ECMO procedure or something like that. And that's something that's, I think, a really good alternative to an emergency situation in the unit.
Thank you. Ulrike Herberg from Bonn University. Do you have any comment on atrial septostomy and stents?
Yes, so I agree to Gerald. We did quite cases in early and later gestation, and we were able to show from histology in those cases who did not survive postnatally that they had really if we are quite late in gestation, then we see the pulmonary hypertension, we see different pneumocytes. So there's a change of the lungs. So you have to do this in an appropriate age. But the difficulty is if you have a very small left atrium, it's quite difficult to place a stent into a small left atrium in a hypoplastic left heart syndrome. It's different to a giant left atrium with closed interatrial septum, because in those patients you have these very sick fetuses with maybe hydrops, but you have a large left atrium, and then it's much easier to place a stent. We always use stents of a size of about 4 millimeters and maybe increase it up a little bit longer, wider. And then in those cases, it's much easier. And then hydrops is resolving and the outcome is better. But I think Anita has collected data and she may tell us something about that, of stents and interatrial septum, closed interatrial septum.
Well, thank you. Yes, the stent and ballooning of the atrial septum experience from the registry has been published a few years ago. I totally agree, stent is the way to go. Most of the septostomies were closed at birth, but the vast majority of the stents were still patent at birth. And if they were patent, half of the babies didn't even need to be intubated prior to their Norwoods. So the stents definitely improved the perinatal stability of the baby. At the time, there were too few patients to show a statistical significance in the discharge survival. So I think that we have data on the technical stuff and far fewer C-sections necessary, far fewer intubations, more stable neonate. So I think there's more work to be done there. The other thing that I wanted to maybe put to the panel is kind of a devil's advocate thing. We're all talking about doing this in mid-gestation, but especially in terms of resource limited countries where postnatal care may be quite expensive. Wouldn't it make sense to, say, balloon an aortic valve up to 38 weeks? Because the big fear is aortic insufficiency, which fetuses tolerate quite well. So you could be more aggressive with the aortic valvuloplasty late in gestation and give the fetus a week or two to recover. For pulmonary valvuloplasty, same idea. When you balloon a critical PS or a PAIVS with a reasonable sized tricuspid valve and still need a second source of pulmonary blood flow, that's more procedures postnatally. Why not do it in late gestation when the ductus is still going to be open for a few weeks and you don't get that suicide right ventricle that you get after ballooning? And same thing with atrial septum. Why not put the stent in at 36, 38 weeks so that the baby is born with an atrial septal communication instead of needing to be rushed to the operating room? Any thoughts?
It's a bit philosophical. Thank you.
Yeah, I mean, it is a good thought. I think that one of the issues with late gestation is you're not able to move the baby because they get wedged in there. Certainly, probably after, well, most of them probably after 34 weeks, they're not moving a whole lot. And so that's probably one of the greatest limiting factors. In fact, we've sometimes had trouble moving them at 31, 32 weeks. The other thing becomes a distance issue with the needle. And then obviously, I think premature labor obviously isn't as much of an issue if it's late gestation. But there is still, obviously the risk of fetal demise, and I don't know whether it increases the risk to the mother. But I think that one of the main issues may actually be fetal positioning.
Agree.
Carlos, you agree?
Yeah.
The fact that one of the reasons why balloon atrial septostomy may be, balloon arterial, aortic arterial valvostomy may be so successful at 20 weeks is that the systolic pressure and the mean arterial pressure is quite low. As you get up towards term, that elevates from, a mean of about 20 to a mean of 50, 60. So the chances of AI being more significant late in gestation certainly seem to be a consideration. Wayne?
Wayne, do you agree to the increase in the BP is a limiting factor for late valvoplasty?
I think by that point, the ventricles are pretty thick. I think one of the limitations there may actually be that if your valve is 5 millimeters or 6 millimeters at that point, we don't have a balloon, you're going to have to start going up on the size of your needle, and then you start to have more bleeding, etc. So, we've never used a needle bigger than 18 gauge in any of our procedures. And one of the limitations there, I think, as Carlos said, is your balloon goes at most to 4.5, even with like overinflating it. So, yeah, so, I think we haven't actually encountered the situation that much needing to do it in late gestation, because the ones we see late tend to just be okay after birth, so it's, and I think there's a little more uncertainty when they're sort of borderline in late gestation, which direction things are going.
Thank you very much, Wayne. I think we should
give Gerald a chance to talk, yeah.
Sorry?
Just a
Gerald
question,
would like
Rima, for Professor Tulser. I think that they have gone a little later in gestation than 32 weeks with the aortic valves. Any comment on this topic?
Gerald?
Yes. Yes, I wanted to cover talk as well, but the latest that we did was 33 plus 1 week. So it was 34 weeks was the latest that we really did. And we did a couple of interventions twice, because we dilated the aortic valve quite early on, 24, 25 weeks, and we saw restenosis occur, or maybe we chose a too small balloon for the first time. So they came back, and at 31, 32 weeks, we did a second balloon dilation. Well, the only concern that I would have is that usually you create a significant aortic regurgitation, and then they have to be quite sure that this baby will become a biventricular candidate. Otherwise, it would be almost lost for an oval procedure if you have significant aortic regurgitation still at birth. And the earlier you do it, the more time the aortic valve has to recover from aortic regurgitation. The later you do and you create late significant aortic regurgitation, then you are in trouble after birth. Then you have to go to a biventricular route, to a Roscona or aortic valve surgery with a well-sized left ventricle.
The question is that technically, do you agree that the late gestation, you will not be able to ask the perinatologist to move the baby right and left as you do, or I've seen you doing it as well. Do you think this is a limitation, or you could go around that? Because the position is very important. It's almost like one of the best factors that will decide if you're successful from the first shot or not, at least my understanding.
Absolutely, but that's one of the biggest problems that we have, at least in Austria. We are not able to position the baby in a position as we like it. So I'm still admire you, Carlos, in Brazil, how you do to manage. We have so skilled obstetricians to put the babies in the correct position. We actually can't do it. We just have to wait until the fetus is in a good position. We just have to wait. And sometimes, if the fetus doesn't move to a good position, we have to stop and don't do it at all. Maybe about 10% of our referrals we send back home because the fetus is not in a good position for 1 or 2 weeks, and then we just can't do it. And the later
we
you
have
are
to
in gestation,
start talking
the
to the
less the
fetuses. We have to start talking to the fetuses.
Yeah.
it's a pleasure, and I'm very sorry to keep Dr. Tulser to the last talk, but he has a very important talk, and I just want to tell you he's one of the best excellent results in doing right and left hearts. But what's interesting that all his patients, my understanding, go for, after aortic valvuloplasty, go for Ross operation. I think this is unique in that center. We haven't heard so far anyone talking about putting it as a rule. And it's a pleasure to listen to Dr. Tulser, Professor Tulser.
Okay, again, thank you very much for inviting me and to give the opportunity to share our experience from Austria. Can you see my slides? Does it work?
Yes, but your audio is a little bit not very clear, Gerald. If you could come near to the speaker, yeah, and make it louder, please. Yeah.
Talk it loud and slowly, yeah. Okay, so actually no disclosure. So this is the our current experience in prenatal cardiac intervention. We just did our case number 200 this year, and you can see for the first 10 years, the first successful intervention was in the year 2000. It was a pulmonary atresia and septum, and then we had just occasional interventions. But from 2014 on, we increased our volume, and now we are doing around 20 cases a year. Most of them, of course, are aortic valve, 132. We had around now 60 pulmonary valves and now 9 balloon atrial septostomy with or without stents. So that's the experience. And of course, as already talked about, there are a number of different morphologies and physiologies in critical aortic stenosis. You have severe EFE, you have hydrops, you can have this giant left atrium, severe mitral regurgitations, and basically we all treat them the same, but there are a lot of different physiologies behind it. The technique that we use in Austria is a general anesthesia of the mother without a separate anesthesia of the fetus. So we don't have to anesthetize the fetus because it is anesthetized together with the mother. The needles that we use are 17, 18, or 19 gauge needles, depending on the size of balloon that we need. The balloon catheters, the smallest one was a 3 millimeter balloon, the largest one, a 5 millimeter balloon catheter that we use. And we also try to overdilate, and you can see on the left, on the lower panel here, the catheter placed in the aortic valve, and when you see the balloon is slightly larger than the aortic valve annulus, between 1 and 1.5 in most of the cases. That's the setting in the OR that we use. One scanning, that's usually me now recently, that's Dr. Arzt Wolfgang, the obstetrician. We do all the procedures together, and we have very good and close cooperation. He has the needle in hands, and the interventionist always is changing, and that's the part where we already have the needle inside the valve. You can see on the screen the left ventricle, the needle now in the left ventricle, and once we manage together to have an optimal angle towards the outflow tract, then the trocar is pulled out. As you can see right now, you can see a little bit of blood coming, and then the catheter is fed into the left forward. And now the balloon is inflated. So that's the setting that we use. A lot has been said about the indication. Again, this is the evolving hypoplastic left heart syndrome with the dilated left ventricle, the reverse flow in the aortic arch, left to right shunt. And the question always is this ventricle salvageable? And we use the left ventricular long axis together with the left ventricular pressure to decide on this. Our criteria have changed over the years. In the beginning, we accepted LV dead score ratios, LV length ratios of -3. Even more recently, we moved to larger left ventricles, but depending on the gestational age, as you can see here. So the older the fetus is, the smaller the left ventricle can be. That was our criteria. A very special topic is the fetus with aortic stenosis and hydrops. And what Jacques asked it's not always about a life-saving procedure, but it's also about improving or reducing morbidity. But once the fetus has developed hydrops, it's definitely a life-saving procedure because the prognosis of a fetus with critical aortic stenosis and hydrops is very poor, and the mortality is close to 100%. We recently published our experience of 14 cases with hydrops. We had successful procedures in all of them, and the hydrops resolved in 9 of these fetuses. We had 3 intrauterine deaths, but none of them was procedure related. And we had 2 neonatal deaths. And alive and biventricular are now 42%, 6 out of these 14 cases, which definitely is much better than natural history. I just want to also give you a few examples what we see. This is the case of severe hydrops at 24 weeks with severe mitral regurgitation, successful intervention. And this is one of the rare cases where we had only 1 fetal intervention and no postnatal procedure at all. So no aortic balloon valvuloplasty, no surgery, nothing at all. We had 5 of these cases in all our cohorts. Now he's almost 3 years old, still without any intervention, a residual gradient of about 30 millimeters of mercury, but nothing else. But from a hydrops case at 24 weeks to a healthy baby without any medication and very good ventricular function, this is one of the really success stories, but unfortunately all of these. That's what Wayne showed us before, 22 weeks aortic stenosis, a couple of weeks later, dilated cardiomyopathy, but very early on and a few weeks afterwards, the function is almost back to normal. Then we see these cases with severe mitral regurgitation, 28 weeks. 1 week after the intervention, the mitral regurgitation is much lower, and in a neonate, it was basically almost gone. So this mitral regurgitation was just due to this high pressure left ventricle. Left ventricular growth after intervention is limited. These are the patients that we followed longitudinally in Linz. Most of the cases here are not from Austria and the rest of Europe, but these we followed. You see the left ventricular lengths absolutely in size increase a little bit, but the Z-score decreases, which means that this left ventricle, they don't grow at a normal rate. Many people ask us about the maternal aspects because we do general anesthesia, but we actually didn't see any significant maternal side effects up to now, fortunately, and no premature labor, no premature rupture of the membrane, no infection, no bleeding. As far the tissue Doppler, just to go quickly through it, is something that significantly improves on the left and on the right side, as well as we have shown here. Complications, well, pericardial effusions that we had to drain, and about 10-13% bradycardias are quite frequent, requiring treatment most of the time, epinephrine into the left or right ventricle in 37%, and thrombi, especially if the procedure takes longer than we expected. Now our experience from over 20 years, we've just submitted this paper, 125 interventions in 103 patients. The success rate now since 2014 is almost 93%. We had altogether 15 IUDs, 11 of these were procedure related, but there was a significant learning curve since 2014, and this was more than 50 cases. Now we have a mortality rate of 5.7%. The median age of gestation was 26 plus 1. As you can see, the median gestation age at birth is 38 plus 2 weeks. What happened to all of these fetuses? 19 of them were successful. All technical failures in our hands became univentricular later on. But the successful cases, you see, these 90 cases, we had procedure-related deaths, intrauterine deaths, deaths before treatment and comfort care. So we had 78 live-born patients. 61 of them were managed towards a biventricular circulation in their referring center. As I told you, most of them are not in Austria, but they felt this could be a biventricular case. So that would be a rate of 78%, which is very high. However, if you see a little bit down the road, there were 2 neonatal deaths. We had biventricular to univentricular conversions very early on in the first month of life. At 28 days, we were down to 73%. And if you look about 1 year later, we have only 59% biventricular outcome out of these cohort. You see there's a couple of biventricular to univentricular conversions. All univentricular managed patients you can see here are listed. Postnatal strategies, of course, are also different, and we not uniformly go for a Roscono procedure in all of our fetuses, not at all, but we try to differentiate. We only go for the Roscono if we see that the aortic valve is really severely abnormal, very dysplastic, and you have a good sized left ventricle with a still good pressure, then it really makes a sense. We had 15 with an aortic balloon, 31 Rosconos, 6 who went on to a surgical valvotomy, 3 had some other kind of strategies, and as I told you before, 5 of these fetuses are all alive, and they up to now didn't need a procedure between now 1 and 6 years of age. So there was no postnatal procedure necessary. The freedom from mortality in the cohort of the live-born fetuses after successful valvuloplasty is seen here. The green line is the biventricular, the blue line, the univentricular line. And you can see there is no significant difference in survival. So, and I don't think we do this procedure just for survival, except that you have high drops. But the goal would be to have a better long-term outcome with a good biventricular management. So this would be the ultimate goal, and maybe you will see it in the 2nd, 3rd, or 4th decade of life, maybe there's a significant difference. But in the early years, as you can see here, we didn't find significant difference in terms of survival. Well, we had no really good control group, of course, but we could compare it to the group of the natural history study from the APC, where they had about 38 fetuses with the same criteria, with the reverse flow in the arch, left to right shunt, the dilated left ventricle, and so on. So it's a historical control group where about 23% became biventricular without intervention. And when we compare it to our cohort, we had about 56.4% at last follow-up. So this was significantly better. But of course, this is a historical control group and not a real control group, we must admit. And the Roscono surgery we apply now very frequently, because we see that balloon dilation in very dysplastic valve doesn't work at all. But these ventricles, they are of course stiff, but they are large enough and they can generate pressure enough. And so our belief is that an early aortic valve replacement really gives this ventricle, especially in the first few months of life, a good chance to remodel. And so we have here, this is an example of a neonate on the left side, and 2 years after the Roscono surgery. This was a pre-intervention at 29 plus 6 weeks, and then 2 years after the Roscono surgery during EFE resections. Another example at 24 weeks and 2 years after the Roscono surgery. So we see remarkable results in terms of left ventricular remodeling and recovery when you unload these left ventricles and give them a perfect growing good aortic valve. We have done now over 50 neonatal Roscono surgeries with quite good Experience had not a single problem with a neo-aortic valve at all, but of course we have to exchange the RV to PA conduit. So in summary, what we tell also the parents is more than 90% of the life-born patients needs any kind of aortic valve interventions. Most frequently, an aortic valve replacement is necessary either in the neonatal or in the infant or toddler's period. The patient still carries significant risk of mortality regardless of the postnatal management, especially in the first year of life, and this has to be taken into account. Survival in our hands was not different between univentricular and biventricular, but we hope that the biventricular group will do better on the long-term run. And overall, there is definitely some evidence that the biventricular outcome rates can be improved with fetal intervention. A few words to PAIVS, so critical pulmonary stenosis. This was the first case that we did in the year 2000, pulmonary atresia intact septum with very high RV pressure. Now, this was the first intervention. Now, she required postnatally a BT shunt for 8 months. That was then taken away. Now she's a 21-year-old lady, still with her native pulmonary valve in place, which is still regurgitant some very large pulmonary arteries, and she might need a pulmonary valve replacement in the near future, but up to now she's really doing fine 21 years later. This was the course that from her, and you can see the monophasic inflow changed to biphasic inflow and the slow growth of the right ventricle. And we know that the neonatal management is strictly dependent on RV and tricuspid valve size at birth, and so we can try to improve it as good as we can before birth. That's the criteria that we used for indicating and pulmonary valvuloplasty from the Boston group based on ratios between tricuspid and mitral valve and the tricuspid valve inflow durations. The procedure is definitely technically a lot more challenging. You can see here once again one of our procedures where you have to perforate the valve, to balloon the valve, and then afterwards should have a good antegrade flow and a pulmonary regurgitation as well. But you have seen these procedures as well. These are the pulmonary valve interventions that we did over the last year, and you can see this 59 interventions have been done in 42 fetuses, because many times we were not successful at the first time and we had to wait for a better fetal position and repeat it later on. Since 2001, we had analyzed or published 35 valvuloplasty in 23 fetuses. At that time, we did not have a single death at all. We didn't lose any patients. However, now, a few years later, we experienced some deaths, but I will come to that later. So this was the baseline, and this was the immediate result, the immediate effects of pulmonary valvuloplasty. Immediately before and after pulmonary valvuloplasty, we saw that the RV was larger, the tricuspid valve diameter was larger, the TR velocity, of course, decreased, and the inflow duration increased a lot. But we don't really think that the right ventricle can grow within 2-3 days so much. It's just a matter of better filling. All of these parameters have been highly significant. And that's how it really looks like before and after the procedure from monophasic to biphasic, a little bit larger and longer right ventricle. TR velocity decreases, but increases again, of course, towards term to really high pressures. And sometimes, of course, you really underestimate the cavity of the right ventricle. And you can, as you can see here in the 2D pictures, you see maybe a very small RV, but if you put on the color, you can see that the color extends all towards the apex. So these RVs are most of the time a lot larger than we think. It's just a muscular overgrowth. And by ballooning the pulmonary valve, you open up this cavity that is present was present before but couldn't really be seen on the 2D picture. The result from our paper that we had, well, we had this pulmonary valvuloplasties graded into the prediction score from the Boston group. As you see, we almost got only biventricular outcomes, especially in the lower scores, but the score of 3, which is this one, would predict non-univentricular outcome in 100% sensitivity in their paper. And this was the group with the smallest RVs. We had 6 successful interventions, and now we have 6 biventricular outcomes in this case. A partial successful intervention was where we just perforated the valve, but we were not sure of if the balloon was really in place or not. And we had one failed intervention, and that became univentricular. So there is some evidence that pulmonary valve interventions really can change the natural history at all. Now the latest update in 2021, we have these 59 interventions. Now we have 3 procedure-related deaths, which is a death rate now from 5%. And 36 successfully treated at life-born patients. We had 4 lost to follow-up from other countries. And we have a biventricular rate of 84%. The rest are 1.5 ventricle, but none of these became univentricular so far. And just a last word to the stenting. This is the classical picture of a fetus with hypoplastic left heart syndrome and intact atrial septum, severely dilated pulmonary veins. A very bad outcome. I don't have to go through this. We had done 9 cases now, 5 cases with dilation alone, no good experience, they all closed, and we had placed now 4 stents, 1 in a critical aortic stenosis. That stent embolized to the left ventricle, unfortunately, but we left it there until birth, and it was removed at the Rosconnor surgery, and the surgeon gave it back to us. We had 2 late stents at 37 and 38 weeks, just a week before delivery. They had good neonatal days, and they all went on to the Norwood procedure. 1 died at Norwood and 1 is alive after Glenn. And we had 1 stent at 28 weeks. That was this case. You can see the severely dilated pulmonary veins with a very abnormal pulmonary vein Doppler. This is how the stent is placed. We insert, we perforated the septum, introduced the wire, and then placed the stent in the atrial septum. So this is the critical part, and we hope that the stent is in a good place and doesn't get lost. In this case, it was a really good, nice procedure. Now you can see that the stent is in place, but the critical part is now to remove the catheter without removing the stent. So this is something that we learned how to do, to remove the wire and the balloon and leave the stent in place where it really is. And this is something really tricky, of course. Now this stent, catheter is removed and the stent is in place and it stayed where it is. So that's how the stent looked like. This is the flow across the stent, and you can see that the pulmonary vein flow is already much better. A lot of flow, a lot of pressure, decompression, and the pulmonary vein flow before and after placing of the stent. So this could have an effect. Unfortunately, this fetus was dead 24 hours later with a huge pericardial effusion, probably because the stent touched the atrial septum and perforated the atrial septum, and the fetus got a huge pericardial effusion. So we don't know about the outcome. Thank you very much again for inviting me and for listening to me, and I'm happy to take any questions now.
Thank you very much, Gerald. Beautiful results as usual. The floor is open for discussion, and please, first we start with the panelists. Do you have questions to Gerald? And then we go to our participants. Any questions to Gerald? Okay, I have a question for you, Gerald, and to Wayne. Now, looking at your results, you more did have Roscono than the valvoplasty. So how would you decide? Do you have criteria? This one will go that pathway, and the other one would go to surgery. It seems that your choice was more towards Roscono rather than balloon valvoplasty postnatally. So what were?
Yeah, well, it was our experience in the beginning. All of these fetuses went into the cath lab for an aortic valve dilation, and we saw that the result was extremely poor. We couldn't reduce the gradient. We created aortic regurgitation, and they couldn't unload the left ventricle at all. And so and most of them had to go on to any kind of aortic valve surgery later on. So we stopped that completely. If the valve really looks ugly and very dysplastic, we go for a very early aortic valve replacement, and to give this left ventricle a chance to remodel and to recover. And we have this sometimes very ballooned, not squeezing huge ventricles. And after the Roscono surgery, they start moving and gaining performance, and that's really absolutely remarkable. I just showed you a few examples of these, but of course the Roscono surgery is a major surgery. That's without any doubt. And but we are very lucky to have Dr. Meyer here in Linz, who really is an excellent surgeon who can do this kind of surgery. So.
Wayne and Carlos, what are your comments about the postnatal management of aortic valvoplasty? What's your experience?
Ulrika has her hand up. Ulrika, do you have a question or comment?
No. I think I have. It's very important. So we are discussing about the postnatal management in those fetuses, which may have a more important impact on outcome than the prenatal management. So this is quite important, and we have 3 different centers and 3 different approaches. So this is very important, and we had the same learning curve regarding postnatal treatment. And I think you, as Wayne already said, you have to find the perfect treatment and have to have nearly all the techniques in your hospital if you treat fetuses with critical aortic stenosis who are ballooned prenatally. So it's not just a simple way and a simple pathway you have to go. And so we have in Carlos Center more the way to go via a hybrid approach, do later operations, but this may harm the left ventricle because you don't decompress the left ventricle early enough. So this has to be discussed. And on the other end, you have the Roscono procedure, which goes for decompression really postnatally, but this can be maybe only done in those ventricles which are clear biventricular or which can be rescued biventricular. And what is with the borderline cases? And this we have to discuss.
Thank you, Rika. Wayne, please.
Well, again, gets back to the original comment, and I agree with Ulrika, is that in the end you have to make the decisions on the patient you have, and it's almost not necessarily relevant when faced with a baby whether they had a fetal intervention. You have to make the right decisions at that time for them, and obviously depending on what you have in your institution. For sure, we look at some of these, I will admit, with a certain bias, and that's and I think there's a middle road to all of this, and the middle road is really what we call left heart rehabilitation surgery, and that's staged, as Carlos was talking about. There's some staged procedures. So if we think the patient is going to fail by pushing them down 2V, where we'll do initial palliative surgery, but with modifications to enable the left ventricle to grow. It's probably a good topic to have a whole nother session on, because I think it's beyond the scope of all of this right now. Obviously, we're out of time, but I'll let Carlos have the last word.
But do you have this? I mean, you must have a protocol in your center. You don't send them to Roscono, from what I saw. I mean, why is that? Do you have a reservation?
Well, we do. No. Actually, of our biventricular patients, about a third of them have actually had a ROS. Maybe not at birth, but eventually, and probably most of them eventually will have one. But it's not, we just make what we think is the best decision. There's no specific protocol for these patients.
Now here, the rehabilitation question, at Linz, they do it at 0 time or whatever time. And Boston, you do it later on, depending on, I don't know which criteria. So it's just wait and see.
Yeah, well, we've done some neonatal ROSs as well. If, obviously if there's severe AR or sub-AS. So we have done it. It's just, you have to look at each patient individually and make the best decision. I don't think you can protocolize it.
Depends on what. Yeah, Carlos, please.
Yeah, well, going back to Ulrich's point, I do agree that we have to unload the left ventricle. So that's why we tend to repeat aortic valvuloplasty in the neonatal period, and then we do a hybrid to see as a bridge to whatever. And of course, although our surgical results have improved a lot in the last 10 years, neonatal surgery for these patients still carries a very high risk, at least in our hands. That's why we postpone the risk to late infancy. So the hybrid approach in our hands works very well for those patients.
So this is very important. Resources, again, and experience is very important in what you decide and what you do in your center, as Wayne said and Carlos. So the message here now, going back to intact septum, Gerald. So if you have intact septum, do you think it's a bad omen? The outcome is not that good, or you think it's okay to have stents and will be okay, and it's an easy procedure, outcome do well? Because as Ulrike said, we have postnatal factors and postnatal disease, not just prenatal. So if you have an intact septum and you have a bad pulmonary venous flow, and do you think a stent will reverse the situation? And do you do pulmonary maternal hyperoxygenation test before you put the stents, or it's not part of the protocol?
We don't do this hyperoxygen test yet. I think it's most likely a really good idea, but we don't have the data to answer this question at all. So only from the one example, that's why I wanted to show this example. So you have this intact septum, you place the stent, and you change, of course, the physiology. You have a better flow out of the lungs, you have decompressed the left atrium, you have a completely changed pulmonary venous flow. And if this has an effect on lung development, or if there has been already an insult that is irreversible and it doesn't work at all, I don't know. I don't know, and I don't know about a way how to find out, other than just because this is such a desperate situation. These fetuses with the intact septum and this nutmeg lungs on MRI. So there's a new form of treatment, and but whether it really works or not, I don't know. There's just a few cases around the world already that had these stents placed, and there is just not enough data to answer your question. But I think, from my standpoint, at least it's something that you can do, and to help these fetuses, but you need at least a couple of patients to find out that you have to follow through pregnancy and see if this lung damage is to some extent reversible or not.
Thank you. Can we have Anita and Dr. Silverman to comment on the stent issue on the intact interatrial septum and from the registry? Anita, please, what do you think? And as Gerald said, there are not a lot of cases worldwide. What do you think?
I think that we need more data, as everyone has said, and I think that the problem is most of the data is hospital discharge, and these are, for the vast majority of them are still going to have hypoplastic left heart syndrome, and so they have to be able to tolerate a cable pulmonary circulation. And so if you only do hospital discharge after Norwood, you're not really getting the information that you want, because it's not really a success if Norwood is their destination therapy and then they're going to die in the first year of life from intractable pulmonary disease. So I think that we've started doing a lot more MRI to characterize the lungs. We're still, I think, a little bit in the dark as to exactly the extent of pulmonary lymphangiectasia in HLHS with moderate and severely restricted septum. I mean, you tend to only get the MRI in the patients that you already know have nutmeg lung, but there's some data from CHOP suggesting that even moderate atrial restriction has lung disease. And I think that as we start intervening on these patients, follow-up lung studies, if they pass away, absolutely histology should be obtained, and all of these series should be following them out at least 2 to 5 years to say, did they actually tolerate their final palliation or not? That's, sorry, I have a lot of thoughts about it. That's all
What about maternal hypoxygenation test? What do you think? Should it be routine? Do you think it works? I mean, the test and giving oxygen to such cases? Because I think it goes back to the pulmonary vascular resistance in the lungs, and it detects if it's responsive or not responsive. So where does it stay? What do you think of maternal
testing?
For testing,
yeah, absolutely. Yeah,
should be done.
The testing works. You know, what's the area under the curve as far as predictive value? I don't think we have enough data yet, but certainly these late gestation fetuses, some of them have reactive tests and some of them do not.
So the ones do not, we will send them for stent, or you will say no?
Would certainly be discussed in our institution, yes.
Great, thank you. Dr. Silverman, any comment on the stent and the intact atrial septum in critical AS?
My experience is also largely in the autopsy room.
Yeah, so it's a bad omen. Okay, I think everybody. Sorry, yes.
I think Carlos had something else to say.
No, a quick question to Wayne. We've seen some extensive resection of the EFE layer on the septum, and this can result in, you know, kind of funny movement, dysfunctional septum with worsening of the left ventricular function. So what are your surgeons doing now? Because they came up with this idea, Pedro and Ram, but sometimes when we see a lot of resection, those ventricles don't behave well.
Yeah, I mean, I think again, these patients are all different. Norman alluded to some of the cases that they had at UCSF and Stanford. Those tended to be very hypertrophied ventricles. I think that you're right. There, some of these we've seen with EFE resection, they get thin wall, dyskinetic. So again, I think one has to choose these patients carefully. And you know, we've seen all types, including ones that have been converted to a good 2 ventricle circulation, but also ones that haven't responded. You know, essentially, you're probably in the end removing a layer of myocardium that's become fibrotic, and so that can't be good for your ventricle necessarily. Yeah.
But it's better, I think, Wayne, if you have a ventricle like that, if you take all of the obstruction to contraction and filling away and leave the ventricle, you've got something better. And also the volume of the ventricle is increased. So if the ventricle can dilate, and even if it contracts by the same percentage, you get a better cardiac output. I mean, I'm not saying that it's perfect.
Yeah, that's
you
right.
Can't manufacture myocardial cells yet. But I think that it certainly relieves a lot of the physiological problems.
In selected patients, absolutely.
I want to ask Anita a question. Anita, does your registry continue to look at postnatal follow-up on these patients? Because the one question we haven't asked, which I think Carlos actually mentioned, is to look at these patients in life. Where do they go? Wayne, you had some data also, 18 years. 55% of hyperplasts are alive in the best institution in the world at 18 years of age. What does the registry show, Anita, and are you looking at that area?
Yes, we have all of the procedures up to the first year of life, and then we also ask for current status to be updated from time to time. We don't have a lot of granular data, but we at least know if they're alive and what type of palliation they have. And then there is our research assistant is looking at trying to get more up-to-date long-term information on those patients for the registry. So it's limited, and it's limited on purpose. The registry was really looking at the procedure itself and maternal and fetal outcomes, because internationally, as we've been talking about for 2 hours, the management of these patients postnatally varies dramatically, and it's just impossible to compare them. So that's sort of where we are. I think that we do need more longer term data, of course, but that may end up coming from these now pretty large single center studies.
Do you believe in what Dr. Qureshi said, question, in a year after the procedure, 2 years, in some cases, cannot cope, and they would go for rotation? Is this part of what you see or what you expect?
Sorry, you cut out there and I didn't hear the whole question.
Do you expect, as part of natural history, after the vulvoplasty in utero, what Dr. Qureshi was trying to say that in a year or two, some of them come with a failing heart and they might need transplantation as part of the natural history. So whatever you've done in utero, it did not change the elasticity and the remodeling and whatever, part of the story. Is this true, or is it just an expectation?
Sure, in some patients. This is why we need candidate selection and we need early diagnosis. But we have plenty of patients now who are normal, healthy toddlers with normal systolic, normal diastolic function. Especially, I'm a big fan of the Roscono in the neonatal period. Get rid of all of the obstruction. And get rid of some of the EFE. And absolutely, you can see what appears to be complete recovery of the myocardium. So I would not say that it is the rule that they are going to have fibrosis and pulmonary hypertension, et cetera. It happens, and they have a lot of that in the Boston series. But you have to remember that the Boston patients early on, they we're pretty much taking all comers, and they have significantly narrowed their criteria at this point. And so the patients that are having the procedure are much more likely to have a success.
Gerald, how old is the oldest Roscono that you have status post valvoplasty?
Status post valvoplasty and a neonatal Roscono.
Yes, please.
Well, we have a couple of them that are 10 years and older, now.
Oh.
And that's what I wanted to say. It is definitely important that the Roscono, no, I forgot what I wanted to say, actually.
I'm getting tired, yeah.
Can I ask you one question about
failing left ventricle? What you said? Those, when we had some cases where we had to go from biventricular to univentricular because of elevated pulmonary artery pressures, even systemic pulmonary artery pressures, because high end-diastolic left ventricle. These were all cases with a too small left ventricle from the beginning, where we pushed maybe too hard, but the problem was not the diastolic dysfunction, was more the actual volume of the left ventricle. All ventricles that had been large enough from the longitudinal standpoint, like we had this EFE resection, they all actually did well and remodeled good. But those who had too small left ventricle from the beginning, these were the one that we had to convert from biventricular to univentricular, and they all died except one.
Last question to the whole panel. What do you think of doing genetic testing to all patients prior to valvoplasty, whole exome? Do you think it's valuable? Could it change the selection criteria or not?
Takes too long.
That's right.
Sorry?
It takes too long. I definitely think that they should all have whole exome and whole genome testing if their karyotype and microarray are normal, but I don't think that we should wait to do the procedure to, unless they can get a 24-hour turnaround. You should not have to wait.
So it's going to happen once it's more shorter and more available. It should be part of the protocol.
Well, we would offer genetic testing to any fetus with an anomaly.
Wayne and Carlos, do you think it's something that should be considered and it will sort of control the outcome later on, long-term outcome?
I mean, we have very few of our patients end up having genetic syndromes of the ones we've done historically. So
it doesn't have to be genetic syndromes. It's just the constitution that perhaps it will tell us who are the ones that would do better than the other ones. What the constitution of your genes, your HLA, whatever. I'm not sure, but I think it will play a role later on.
Yes. I just want to make one further point about the Roscono. It's a wonderful operation, and I think that we don't have much choice in the neonate in terms of offering other procedures. But the other argument always about the Roscono later on in life is that you're replacing one valve disease with two valve diseases. And conduits are wonderful things, but there's just recently been a paper in the World Journal of Cardiac Surgery that the average survival for a homograft is about 5 to 6 years. So basically, if you look at this for plotting in life, the answer is not over with the end of the Roscono. We've had a number of patients where they've had their homograft valve replaced twice, and the Roscono is still holding up. But I mean, it does create a problem on the other side of the heart that is also going to be responsible for looking at long-term outcomes in these patients.
Okay. I think it's a very reasonable comment. Gerald, what do you think of what Dr. I think this will be, we have to end, but what do you think of what Dr. Silverman said? You're replacing one disease with two valve disease.
Yes, but absolute value. This is one of the drawbacks from the Roscono procedure. Definitely right, especially if you do it in a neonatal period. These homografts, they last you have to, usually 3 to 5 years, you have to replace the first time. Then, of course, you can take a homograft that can be replaced with a melody valve or with a percutaneous valve later on. And the surgeons have to take care a little bit about the coronaries, that a melody valve can be implanted later on. But definitely, that's right. You have a two-valve disease afterwards. The neurotic valve doesn't really make any problems, but the RV2 conduit really creates problem exchange and endocarditis. Recently, we had a couple of endocarditis cases as well. Yeah.
Thank you very much. I would like to thank all speakers and panelists and really for such an important discussion. And hopefully we'll meet again in the Congenital Heart Academy. And as we say, this whole webinar is available on the YouTube on the Congenital Heart. And thank you again and again.
Thank you.
Bye. Thank you, everybody.
Thank you, guys. It was great.
Bye.
Great job.
Thank you.
Organizing, yeah.